Your Health, Your Choice. I am Dr. Roopnarine, and we're coming to you live from our studios at ACTN. On tonight's program, we're going to be discussing the very important topic of breast cancer. In studio with me tonight is Dr. Rishi Ramraj. Dr. Ramraj is the current head of surgery at the Point 14 General Hospital. Dr. Ramraj also has offices at the Gulfview Medical Center and the SurgiMed Clinic in San Fernando. As usual tonight, our numbers should come up at the bottom of your screens, and we will make our very best effort to answer each and every one of your questions during the program. So guys, today is Wednesday, the 27th of July, 2022. We're going to be discussing breast cancer, and let's say hello to Dr. Rishi Ramraj. Doc, how you doing? It's a pleasure to have you on the program. Welcome to Your Health, Your Choice, Rishi. Glad to have you.
Thank you very much, and I'm very happy to be here.
All right, Rishi. So, Rishi, breast cancer is a very important topic, right? It's a very common illness in society, and it's something that we were talking about earlier on, about 2 weeks ago, and it's something that I really appreciate someone like yourself, a surgeon who has a role to play in breast cancer treatment, coming on the program and discussing with the public about breast cancer. All right, so Rishi, I'm just going to start you off really simply, right? What is cancer? Because it's a term that people hear all the time. People might not fully understand what is cancer, but they might know the word. And with that word comes certain feelings and emotions and negativity, right? But can you just explain to our population, to the viewing audience, what exactly is cancer?
So, as you've rightly stated, cancer brings on all these thoughts and feelings and connotations.
Of course, Richard.
But medically and surgically, you know, cancer is a disease at the cellular level.
Right.
Right. Our entire body is made up of cells, right?
Correct.
So and of course each structure in the body is made up of cells. So if we look specifically at breast and breast cancer, the cells within the breast, they normally divide and multiply, and for healing and normal production, milk production and all of that.
Yeah.
But with cancer, what happens is the cells start to divide abnormally. So they divide unchecked, and they grow rapidly, they grow without control, and oftentimes it results in a mass, a tumor, or a growth, as we would say, and basically that's it. But at the end of the day, it's a cellular abnormality. It's an abnormality at the cellular level.
Right, and that's true for any type of cancer in the body.
And that is true for any type of cancer in the body.
All right.
Yes.
So let's get specifically now to breast cancer, right?
Yes.
So cancer is just an unchecked multiplication of the cells that results in a mass.
Yes.
But how common is breast cancer in Trinidad and Tobago, and how common is it in the entire world?
Right. So specifically for Trinidad and Tobago, we have some data that's a few years old, but it's roughly about 60 women per 100,000 of the population annually, right?
Right.
That's the incidence. So, and we look at 674,000 women in Trinidad. So we're looking at about between 400 to 450 women diagnosed with new cases of breast cancer every year in Trinidad. And unfortunately, about 27% of those die annually.
All right. So every year we expect about 450 women to be diagnosed with breast cancer in this country, which is a lot.
It is a lot.
What is the worldwide prevalence of breast cancer?
For currently, annually there's about 2.3 million cases worldwide. There are about 7 million women living with cancer as well worldwide. Unfortunately, about 600,000 of them die every year from breast cancer.
Okay. My question, Richie, is breast cancer more common in Trinidad and Tobago than other parts than the global average, or are we on par with the global average?
We are actually a ranked number 17 in the world.
17?
17, yes.
Okay.
And so that puts us in the top tier, the higher.
For breast cancer?
Yes, for breast cancer.
All right. Is that Trinidad, or is that, I mean, you're you're a man that worked up and down the Caribbean. You're a real
Yes.
Caribbean surgeon, right?
Yes.
Is it very common in the other islands as well? And
It is common.
Yeah.
It is common. I honestly have no data to suggest that it is more common, but it is
Okay.
a very common condition throughout the Caribbean.
Okay.
There's lots of data that do suggest that breast cancer is actually more common in people of African descent,
Okay.
which is the vast majority of our population within the Caribbean. And worldwide, breast cancer is actually one of the leading causes of death and one of the most prevalent cancers around.
Okay. How would breast cancer rate in terms of the prevalence of the other cancers? In terms of mortality?
In Trinidad,
No, worldwide.
Worldwide?
In Trinidad, sorry.
in Trinidad, there's lung cancer, colorectal, breast. Those are the top three.
Okay.
And and prostate as well in men, right?
Of course, yeah.
But the figures that we have are not exactly current, given the situation of the past few years.
Yes.
So we don't know, but it definitely is in the top three.
All right. So, Richard, what you're saying is quite revealing to me, because obviously it's Trinidad the top 17th ranked in the world for breast cancer. Now, why do you think it's more common? Is there any reason why it's more common in Trinidad? Or is there no research done to suggest any causative reasons?
Well, we could postulate. Could postulate that Trinidad is one of the higher socioeconomic countries in the Caribbean. That's one.
Right.
So we have access to more westernized diet and lifestyle.
Okay.
And which leads us into one of the risk factors, which is the consumption of these foods with lots of preservatives and so on. It's a small risk factor, but it's there. Obesity is another risk factor for breast cancer.
Yeah. What are the other risk factors?
Primarily with breast cancer, hormones are the main thing, right? So you'll see when we see a young lady, any lady, I generally say young lady because most of them are young in spirit anyway. But whenever you see a young lady, and we ask her, oh, when did you start having periods? Have you gone through menopause? What age was it? How many kids you have? Did you breastfeed? These are the questions that hormone use, contraceptive use. These are all identifiers of risk factors. And for breast cancer, a lot of the cancers are hormone driven, hormone dependent. So it's hormonal exposure.
Right.
Whether it's endogenous from the woman herself or exogenous with the hormone replacements or the oral contraceptive use.
All right. So hormone exposure duration is the number one risk factor.
Yes.
We would say for development of breast cancer.
Yes.
You were saying diet is also a possible risk factor.
Yes, the Western diet has not specifically for breast, but in general.
Okay.
Poor diets do lead to increase in the incidence of cancer. Processed foods and stuff. There is a small association with the breast cancer as well.
What are other common risk factors other than the diet? Are there any other, or mostly it's just hormonal really? Mostly
hormonal, but we do have. Specifically for breast cancer, you do have hormones. Well, we did say hormones, but you do have things like smoking, which is a general risk factor for all cancers,
including breast cancer.
Including, but there's a specific association with increased incidence of breast cancer. Regardless, obesity is a risk factor, and the reason for that is that the fat cells tend to convert the pre-estrogen type hormone into estrogen, and so the fatter women tend to have increased estrogen levels.
Right.
And alcohol intake, unfortunately, is a risk factor for breast cancer as well.
Right. If you could explain a little bit more about what you mean by hormonal exposure.
Right. So the breast tissue,
Yeah.
as every woman goes through puberty,
Yeah.
She develops breasts, right?
Of course.
And as you're going through puberty, your ovaries start producing these hormones, and the body converts the pre-estrogen into estrogen, and so on, and that stimulates changes within the breast, right?
Yes.
So the cells
Yes.
lining the ducts that produce the milk are stimulated by the estrogen and the progesterone, the female hormones then, right? And so starting periods early,
Yes.
or finishing periods very late, not having kids, not breastfeeding, means that you are exposing yourself to a greater length of time with the exposure to these hormones.
Okay.
Right?
Breastfeeding is a very, very important topic at the moment.
Yes.
What is the link between breastfeeding and breast cancer?
That is actually a really good question, and breastfeeding is actually protective.
Okay.
Right? Breastfeeding is protective simply because, so we had said earlier, cancer is as a result of this cellular abnormality, right? Oftentimes what happens is the cells, the cells have DNA, and they oftentimes can mutate, and this mutation leads to the abnormal replication, right? Cells which are not mature, so they are more likely to undergo mutations, right? Whereas if, for example, a woman has had kids and is breastfeeding, you've stimulated the lining to become the mature cell line. Mature cell lines don't mutate as much.
Right, they mature they're more likely to mutate when they're immature. And
yes, exactly. So mature cell lines don't generally don't mutate, and so breastfeeding becomes a protective factor for breast cancer.
Right.
Same thing with kids. Having kids earlier means that I'm not advocating teenage pregnancy now, but having kids earlier means that you are not exposing yourself to that unchecked estrogen throughout your lifespan. So you reduce your risk by having kids as well.
Right. Any specific medications other than the oral contraceptive pill that might be at increased risk of breast cancer?
Right. So
because people in Trinidad, a lot of times we take a lot of medication. Sometimes we are a society that take a lot of medications, right? And sometimes people take medications without medical guidance, or sometimes, I mean, when you open up a package, it's loads of fine print, and the understanding of what is suitable for you might be difficult for the layman.
Yes.
Maybe possibly marketed deliberately that way, you never know. So is there any medication that people might be using right now that they need to know that, hey, listen, this might contribute to breast cancer, or before you use it or while you're using it, please check a doctor to make sure you're not going to develop breast cancer?
Right. So the first thing that you're asking, apart from the oral contraceptives, is what we call hormone replacement therapy, right?
Okay.
Now, hormone replacement therapy is something that is used, with the women who are going through menopause, and they have the hot flashes, and it's very uncomfortable, and they become very miserable.
Yeah.
I've heard. So the hormone replacement therapy actually smooths out that process, so it helps them. But there was a study that was released in the very early 2000s that suggested that women who use hormone replacement therapy actually have a 4-fold relative risk for developing breast cancer. So since then, people have stopped being very, they've become more selective about using it, right? To continue with the question, other things, vitamins, right? People have suggested, the cancers, they feed off of your body, they feed off of the cells and the nutrients in your body. There's no positive association really between vitamin use and cancer. In fact, it as a part of a healthy lifestyle, it can be beneficial. And then there was a very controversial topic about people who use iron supplements.
Yeah.
And initially it was thought that these things would have contributed to the formation of breast cancer. But meta-analysis have shown that that's not so, except in a very small subset of what we call hormone receptive cancers. Very small.
So, that's good. At least you give us an outline of what the breast cancer, the risk factors, and we spoke through that. So I just want to push on now into hardcore. Like, what would you suggest to women out there? Because the main part of cancer treatment or cancer care or health really is preventative medicine. Preventative medicine is the hallmark of medicine.
Yes.
Right? How would you recommend to women, or what do you recommend to women in terms of screening for breast cancer?
Right.
At what age should they start screening for breast cancer? What age should they stop? We all know that mammograms is part of screening for breast cancer.
Yes.
How often should they do mammograms? Just give us some insight into screening for breast cancer.
So, women should be screened from the age of 50 every year.
Okay.
Right, until about 59 years old.
Right.
Now,
when you say screening, what do you mean?
When we say screening, we are talking about screening mammograms.
Okay.
We don't have an official screening program in this country.
Yeah.
But a lot of the banks and outreaches
and the GPs reach out to the patients. Yeah.
And so we have a form of screening.
Yeah.
But it's not it's not an official national protocol that is in place.
So is it every year that women should have mammograms?
So every year from 50 to 59, and then biennially after that. Actually after 69. 50 to 69, right? And then biennially thereafter, and you can stop at 80 because the benefits don't outweigh the risk at that age. However,
go on.
Between 40 to 49, although not widely recommended, all of the societies do suggest that if the woman's choice to decide whether she wants to be screened or not.
Yes.
Right? This is in women of average risk.
Yes.
In women who are of higher risk, especially those who have genetic mutations like
family history.
Family history is actually, I normally tell the medical students that family history is almost like identifying a genetic mutation. Okay. Because if your mom had breast cancer at a young age, we should have genetic counseling and testing to make sure that it is actually not a familial mutation.
Right. So those screening guidelines that you gave was for the regular population of no risk factors as such. Right. And that's screening guidelines if everything goes along nice and normal all through the years.
Yes.
What before that, women should do self-exams as well, or? So
yes. Nobody knows your breasts better than you. Mm-hmm. I mean, as a woman. Mm-hmm. We had sent one of the breast self-examination.
You have a slide there? Josh, if you could pull up this slide on the self-exam, he'll bring it up there. Look at there. You can talk through it.
Right. So every woman should do their breast self-examination. Basically it's like a 5-step process. Mm-hmm. You do it at a fixed time at every cycle. So usually between 3 days to 5 days after your periods, mm-hmm. And you try to keep to that time span after every monthly cycle, right? Mm-hmm. Now, 5 steps. The first thing is you stand up in front of the mirror, mm-hmm. and you look at yourself. You look at the breast for any abnormal bulges, mm-hmm. any dimpling, mm-hmm. any skin color changes, right? Then you do that with your arms to your side. Yep. Then you repeat the process. So step 2 is putting your arms up, which can accentuate any masses that are in the breast and can help you identify any visible lesions. The third step is to assess the nipple. You look at the nipple in the mirror. You look to see whether there's any nipple retraction, whether there's any scaliness or crustiness around the nipple, and you look for nipple discharge.
Right.
All right. Then the fourth step is lying down and palpating. So palpating basically means just feeling, the breast tissue. And normally you'd use the pads of your 2 fingers and go around. So you can start in, you can do in increasingly concentric circles, or you could do linear from top to bottom, so, or up and down. And, and other people prefer the centripetal, meaning like the spokes of a wheel from the center out.
Okay.
But it all depends on personal preference for the patient.
Okay.
But the main concept is that you examine the entire breast.
Right.
Right arm for left breast, left arm for right breast.
And you look for any changes.
And you look for any changes,
All right.
yes.
So, Rashid, now is a good time for us to take a little commercial break. All right. So, guys, we're going to take a little commercial break. My name is Dr. Roopnarine. I'm here with Dr. Rishi Ramraj. He's a consultant surgeon in Point Fortin, and we're discussing breast cancer. I would like to formally invite you at this time to send in your questions or comments to us, and Dr. Ramraj will do his very best to answer it. All right, guys? So we'll be back in one moment.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
ACTN The Voice launches a new and versatile culinary series called Stacy's Kitchen.
Hi everyone, welcome to Stacy's Kitchen. And on today's episode of Stacy's Kitchen, we will be cooking up a Thanksgiving feast. Our rolls are ready and looking yummy. Nothing like a good curry chicken and some basmati rice. So I'm gonna start putting my wings in to fry.
We will showcase how to make tasty international cuisine with our local products. We emphasize meals on a budget with our selected ingredients.
Restez à l'écoute, Stacy's Cuisine. Au revoir.
So you can put how much, depends on how big you want it. So our fish is ready. Oh my God, look at that. Oh my God, oh my God. Just like paratha, this is lovely.
Join us on ACTN on Monday evenings at 6:30 p.m. Don't miss Stacy's Kitchen, exclusively on ACTN The Voice.
All right, guys, welcome back here. We're talking about breast cancer. I'm here with Dr. Rishi Ramraj. So, Rishi, before we went to break there, right, you were showing us how women should examine their breasts. Now, I suppose the big part of it is a woman is at home, one of the viewers, they follow your advice, they go and they check in the breast and so on, and they feel a lump, right? And they feel something that abnormal that they didn't notice before.
Right.
I suppose the next step is that they come in to see the doctor like yourself, right? Or come in to see somebody like myself.
Yeah.
Just take the patients through, right? What would happen after they feel the lump and they come in to see you? What happens next?
Right. So what happens immediately they find the lump is that they become very scared.
Exactly, yes.
Right?
Yeah.
Their first thought is, oh my God, this is cancer.
Yeah.
Right? Fortunately, only about 10% of the lumps will actually be cancerous.
Right.
All right?
Yeah.
However, 10% is still a lot.
Yes.
That's on lumps discovered, not necessarily on self-examination, but even by the doctor, during a checkup, or by the partner or whoever, right?
Right. So they discovered this lump. They haven't done any screening whatsoever.
Right.
Obviously, the patient will be very nervous and anxious. But can they say, hey, Dr. Ramraj, have a bump or a lump in my breast.
Yes.
Yeah.
So they come in and they what we do and
Yeah.
what is standard practice worldwide, and we
Yes.
ask all the medical students this question in the final exam.
Yeah.
Is how do you assess this patient that comes to you with a breast lump?
Yeah.
And the answer is triple assessment. What do we mean by triple assessment? We mean clinical assessment,
Yes.
which is the history and physical examination.
Yeah.
So, which is what we talked to you about the risk factors, which we went over a
Yeah.
little earlier.
So you go through that with the patient.
Yes, we
Yeah.
look at the breast, we examine the breast for all the little signs that we talked about, the lumps, any discharge of the nipple retraction, changes in the skin color, masses. We also look for masses under the armpit, all right?
Okay.
So that's a clinical aspect of
Yeah.
it, clinical assessment.
Yeah.
The second assessment is radiological assessment, right?
Yes.
And radiological assessment is mammograms, especially for those women who are over 50 years of age, and ultrasounds for women who are under 40.
Right.
All right? And in between that, depending on how much information you get on your imaging, you can actually choose to do both
Okay. Of course.
imaging modalities to
Right.
document the lesion that
Right.
is there,
Yeah.
but also to assess whether there are other lesions in the same breast or other lesions in the other breast.
Right. I'm going to stop you there for a little bit.
Yeah.
Sorry. Yes, we know that we're talking about breast cancer, right?
Yeah.
But this is a patient who comes with a lump. Now, just to put things into perspective, as I said, not all lumps going to be breast cancer, right?
Yes.
So just briefly, very briefly, like 1 minute, just tell the public what other lumps that they have that might not be breast cancer.
Sure.
Because people need to know that there are other lumps other than a cancerous lump.
Sure. So you have by and far the most common is what is known as fibroadenomas.
Yeah.
You'd find these in the younger age group, but that doesn't mean that an older woman cannot have a fibroadenoma.
Right.
Usually it may have been there since the more youthful days, and may only now have been discovered. That's
Right.
one of the things. You have breast cysts, which
Yeah.
are simple cysts. You could have abscesses.
Yeah.
You could have things like what we call fibrocystic change,
Yeah.
and other rare things like thrombophlebitis in the breast.
And those things are quite common as well.
Yes.
I mean, you pick them up as well.
Yes, you do see them
Right.
sometimes.
So the lady so this patient with a breast lump, we do the mammogram, we do the ultrasound, and let's say something is suspicious on the mammogram. What happens next?
So the next step is pathological assessment, right?
Yeah.
And pathological assessment basically is doing a biopsy.
Okay.
So we need to do a biopsy. Normally, in this day and age, the biopsy is what we call a core needle biopsy. So it's a big needle as opposed to fine needle aspiration. Core needle tells you whether you have an invasive type cancer, meaning cancer which has breached the lining around the duct and has invaded into the breast,
Yeah.
as opposed to ductal carcinoma
Yeah.
in situ, which is malignant cells, cancerous cells,
Yes.
but they have not become invasive as yet. All right. A lot of the screening that we do in patients who don't have masses, who just undergo a general screening mammogram, you find DCIS, which is pre-invasive breast cancer, basically.
Appreciate it. That's one of the biopsy of breast lumps, right? I mean, this is a real clinical thing that patients experience every day, and it's something that I see in my clinic as well, right?
Yes.
Not all the time, depending on the patient, not all the time does the mammogram give you a definitive answer, or does the mammogram necessarily say that somebody has something suspicious. For example, I'll give you a clinical scenario, right? Maybe about 5 years ago, I had a patient who was over 50 years old. I felt something in her breast, and she felt something as well. And we did the mammogram and we did the ultrasound, and they didn't really see anything suspicious. I think they might have actually reported it as somewhat non-suspicious. And I was discussing it with another doctor as well, and first instinct was to do the biopsy regardless. And it turned out that it was cancer.
Yes.
So why I'm saying that for is that sometimes people might, that's why people must tie in with a doctor
Yes.
Now, there's a kind of thing where people go for the breast screening, they go for the mammograms, and they're outside of the circle of the doctor, but they
Yes.
take it upon themselves. But that doesn't mean that you interpret radiology and stuff on your own.
Yes.
And because you read something normal, that it means it's normal.
No.
And I think we've seen a trend of that too. People doing the x-rays and they're getting stuff and they're reading everything normal and they say it's normal, normal, they look it up on the internet and off they go.
Yes.
But there's no substitute, regardless of radiology or whatever, for a clinician's or a doctor's sort of instinct.
Yes. Well,
And what I described there is actually not just one case. Myself, I had about 3 cases over the years, and I've been in practice for about 15 years. So I could have seen those patients if they didn't tie in with myself and the system like you.
Yes.
They would have gotten their mammograms, done everything, seen it as normal, and gone off.
yes.
So that's my point, and that's my point to the public, that
Yes.
you really, it's innate skill that we develop as doctors that sometimes ties in with the radiology that makes us do things
Yes.
and do further testing. Am I correct on what I'm saying? Do you understand what I'm saying?
Well, you know, a lot of the times people do, especially the older clinicians, they say surgery is not only a science, it's an art. And in fact, medicine in general.
Yeah.
Right? And yes, the reports can be inaccurate.
And it's not because the radiologist is making a mistake either.
No.
He's reporting what he's seeing. It's just the
Yes.
nature of technology
Yes.
and where we are at this stage in medicine and what the quality of the imaging we have and the nature of the person's breast. Am I not right?
You are absolutely correct. So you
Yeah.
have the patient factors,
Yeah.
and you have the medical factors, the doctor factors,
Yeah.
which can determine, you know,
Yeah.
whether you act on the radiological
Yeah.
findings, right?
Yeah.
So clinical suspicion
Clinical
is
suspicion.
also a very important factor in making these types of diagnoses.
Do you think that all women over the age of 50 or 60 who has a breast lump should be biopsied? Is it in the guidelines or is it not in the guidelines?
Right. So above 50.
Hard question.
Above 50, yes.
Okay.
As long as you have a lump.
Yeah.
And it is in the guidelines,
Yeah, okay.
but as with your personal experience and my personal experience, we have radiology saying features are suggestive of benign disease.
Yeah.
But because of the guidelines and because of the age, so as you get older, your risk for breast cancer increases. And because of that age, yes, and every woman over 50 with a breast lump gets a biopsy.
Right.
Yes.
Right. And that's in the guidelines too?
Yes.
Okay. Good. So we're doing the right things.
Yes.
Rishi, so this patient that you have, let's say she's 50 years old, it's suspicious on the mammogram, you did an ultrasound, and then you do a biopsy, and then the pathologist takes over from there. And how does the pathologist help us, and what happens to the patient afterwards?
Right. So the pathologist confirms whether this is a cancer or not, right?
Yeah.
So in the unfortunate percentage of women who are positive for malignancy,
Yeah.
they would need to undergo what is known as staging of the cancer.
Right.
Right now, breast cancer staging is very important because the staging determines the prognosis,
Yeah.
and the staging also determines what treatment options are available to the patient.
Okay. So how do you stage a patient?
So clinically, you assess the size of the mass. So it's what we call the TNM staging, tumor, nodes, metastases, right? So T is staged by the surgeon or the GP or medical the office doctor examining the mass. And now the mass is so T1 is a small lesion, less than 2 centimeters. T2 is up to 5 centimeters. T3 is greater than 5 centimeters, and so on, right? And nodes, the breast drains all of the lymphatics drain into the glands under the arm.
Right. So that's an important point, right?
Yes.
Because a lot of the times, this is for the public to understand as well.
Yes.
Even the doctor, when they go to the doctor's office, the doctor's going to examine the breast, but the first thing he does is go under the arm. Sometimes, right?
Yeah.
And the patient is like, why is the doctor going under my arm? So sometimes a patient might not see any changes on the breast, but they might notice something under the arm.
Yes.
And they might notice a gland, and that's something they need to see the doctor about, right?
Yes.
So the reason being is what you just said. Sometimes the lymph nodes from the lunchtime, the lymphatic system drains down under the arm.
Right.
So that's important so people understand the rationale of why we do things. Because sometimes they ask me, doc, why you going on my arm? Breast. But the breast, under the arm is very important because we check for glands and nodes.
Yes.
All right, so continue on.
Right. So disease that is confined to the breast would be early stage disease or what we call local breast cancer.
Yeah.
If it's under the armpit, then that is what we call local regional or regional disease, right?
Right.
Which is slightly more advanced,
Right.
but still very eminently curable.
Yeah.
And then the other part, the M part, which is metastases, you're looking for distant spread.
Right.
And distant spread, we need to use things like our CT scan. Sometimes you use PET scans to do it as well. Even simple ultrasound and liver function tests you can utilize as well.
Right.
All right, but in this day and age, the CT scan is the preferred modality for the most accurate assessment for metastatic disease. Okay. Metastatic disease means it's spread, and at this point in time, metastatic disease is not considered curable in breast disease. However, there are studies looking at what we call oligometastatic disease, which is isolated mets, so maybe a metastatic deposit in the lung or a metastatic deposit in the liver, or 1, 2, 3 small numbers that can be resected, but that's only in the context of a clinical trial.
All right. So we've staged our patient, right?
Yes.
Who becomes their team of doctors? Who's their team to help them look after them in the public health system, in the private health? Who's their team? You are part of the team. You're the surgeon.
Yes.
But there are also other parts of the team. There might be a psychiatrist or a psychologist or experienced patient support group.
Right.
Might be the GP. We are part of their team as well.
Yeah.
Who else is part of that team to help look after that patient?
So you say this surgeon, but what we could say is a surgical oncologist.
Okay.
Right?
Yeah, go ahead.
So after breast surgery, so breast surgery is one of those things where it's very curable, and there's a lot of information, data, and knowledge by the clinical or the medical oncologists.
Yeah.
So those are the doctors that are responsible for giving you your chemotherapy, for prescribing your radiation, and of course you will have the pharmacists and the radiation techs, and as you said, the psychiatrists, the support group. You'll need physiotherapists as well, because it's a if you have the modified radical mastectomy, you will need rehabilitation.
So maybe I jumped there a little bit.
Yes.
But maybe I did jump, because after the diagnosis of the staging, who else becomes involved in the care there? The oncologist as well.
Right.
Yeah.
So early stage disease. So this is where breast cancer is so very interesting.
Yeah. And this is modern. This is where we push in the boundaries of medicine.
Yes.
And this is a great part of medicine. And this is the advances in medicine. A lot of it has to do with the oncologist.
Right.
And this is where we get into increased survival.
Right.
So tell the public about that.
Right. So breast cancer is no longer a death sentence.
Exactly.
Right?
Yeah.
It is no longer a death sentence.
Yeah.
Over 90% of patients with early stage disease that's confined to the breast they are able to be cured, meaning a 90% plus 5-year survival rate.
All right. Now, I'm going to interrupt you again.
Yes.
Now, I just want to bring this back to the public. Why that is important, what you just said, that 90% breast cancer is no longer a deadly sentence, is because, believe it or not, as GPs in Trinidad and GPs all over the world, in Ireland, England, we still see people or patients that, because of fear of breast cancer or fear, they don't go in for treatment.
Yes.
And sometimes when they come in very late.
Yes.
And sometimes we see a massive cancer that it's already eroding through the breast.
Yes.
And we're like, okay, were you no doctor? She was just scared, or mommy was just scared to go into the doctors, scared that it's a death sentence. And that's unfortunate. And we see it all over the world still.
Yes.
Even when I practice in different countries, I've seen it in different countries as well. That women sometimes, because of fear, present too late.
Yes.
And it's usually downhill after that into palliative care.
Yes.
But what we are saying, and it's really important, is no. Come out, see the doctors. It is not a death sentence. No. Medicine has advanced, right? And we're curing these things now.
Yes.
We're curing these things.
Significant cure rates, all right?
Yeah.
And with modern surgery, with modern medicine, modern chemotherapy and radiation,
Yeah.
you don't even have to lose your breast
Right.
to survive breast cancer.
Right. Amazing.
Right? There is, so when we spoke about the local disease
Yeah.
confined to the breast,
Yeah.
we can actually offer what is known as breast conservation surgery.
Yeah.
Right, where you take out the tumor
Yeah.
with enough margins,
Yeah.
and then you move the tissue around and close up the breast. There are various different techniques
Yeah.
that you can use. I mean, it's probably a little too detailed for you.
No, that's fine. So you're actually removing the cancer with enough margins and enough clearance, but yet maintaining the structure of the breast. Is that what you're saying?
Yes, you're maintaining the structure of the breast.
Right.
Now, in order for this to occur,
Yeah.
for this, so before we used to do what is known as modified radical mastectomy, where you take out the entire breast, take out all the glands under the arm.
Is that happening much again?
It's happening here.
But it can be avoided.
The incidence is much less than what it used to be.
Right.
Yes, it can be avoided.
Yeah.
Not in all cases, but it can be avoided. So for the lumps that are confined to
Not
the
with
breast and
Yeah.
no glands under the arm, breast conservation and radiation to follow up
Right.
with chemotherapy
Right.
is equivalent to doing that modified radical mastectomy.
All right.
Right.
So, Doc, I just want to interrupt you a little bit.
Yeah.
Josh, we have some questions coming in. All right, you can go ahead. We'll take it as we go along. All right, you can put it up. So we're just going to take a little feedback from the audience at this stage,
Sure.
all right?
Yeah.
And we'll probably just push through because a lot of information to get through. The question there, Doc, is there a national breast cancer screening program in Trinidad and Tobago? Doctor?
There is not a national breast cancer screening program as outlined in protocol by the government.
Yeah.
However, there is an ad hoc or informal sort of screening system
Yeah.
where the patients go to the GPs who
Yeah.
screen them. They have the national, the banks do some cancer awareness
There's mobile
drives and
mammogram
screening.
units as well.
Yes, and there are mobile mammogram screening units, but there is no policy in place at the national level for global screening, meaning global screening of the female population in this country. But you know, it's
That's
something
unfortunate,
that
isn't
it is unfortunate. Neither is colon cancer, which is you know, and these are the two cancers that screening programs actually have worldwide have boosted up the detection and survival and cure rates
Yeah, of course.
immensely.
So basically, the science and the medicine has been advanced, yet
Yes.
the policies have
You know,
trailed behind.
I think it takes time to implement these things, but I guess somebody has to become cognizant of
Yeah.
it on a
You're
national
currently
level.
things now.
Yes.
Any other questions there, Josh? Is breast conservation surgery available in the public sector? Good question.
Absolutely, absolutely. Breast conservation surgery is available in the public sector.
You all do it?
Yes.
Okay.
But you do have to fit the criteria, that's one.
Yeah.
And two, you need to have radiation within 42 days.
Right.
Right? Sometimes it's in the public sector, it's hard to access radiation within 42 days
Yeah.
to achieve the benefit.
Yeah.
And some people do get a breast conservation and go privately for the radiation and chemo,
Yeah.
or sometimes, you know, once things work well, they
The
can
system turns over. And
yes,
works
and
good.
they can
You
get
get everything done in the public
Yes.
system. So that's a big yes there, that viewer. Josh, before we continue on. Okay, does the public sector do immediate/delayed breast reconstruction for breast cancer? Good question again.
Yes.
That's a good question, doctor.
This is actually a wonderful question.
Yeah.
Now,
What is breast reconstruction? For the benefit of the greater public, what is
Yes.
breast reconstruction? Why is that question such a great question?
so remember we spoke about the psychologists and counselors to speak to these patients
Yeah.
about the breast cancer. One of it is not only the breast cancer diagnosis, but one of the things that women do feel and suffer from is that loss of femininity. They you know, it affects them because of the loss of the breast, and they
course.
feel, you know, they've lost their femininity
Some women, yes.
and their appeal, right? Some
Yeah.
of them do.
Right.
And so reconstruction and plastic surgeons are an important part of the therapy for breast cancer. Immediate reconstruction, you can use what we call tissue flaps. So you mobilize flaps of tissue usually from the abdomen or from the back, and to create the breast mound. And these patients, if it's likely that they would not need radiation, right? Now, delayed reconstruction, you can do it if the patient may need to have radiation.
Yeah.
So you remove the breast, you do the cancer treatment,
Yeah.
and then you come back later once the cancer treatment is finished. So the radiation, the chemo,
Yeah.
and you do the reconstruction. Now we have natural reconstruction, which I mentioned, the abdominal flap
Yes.
and the back flap.
Yes.
But we also have delayed implant reconstruction.
Right.
Right. Now,
And that's being done in the public sector?
so it used to be done.
Yes.
I don't know what is happening
Okay.
currently.
Okay. Not sure
but
the status of it.
but we haven't seen the implants for a long time because
But the natural reconstruction is being done?
natural reconstruction has been done, but again, the patient has to fit the criteria.
Right. And that's done by a plastic surgeon?
Plastic surgeons do it, general surgeons can do it.
Right.
It's
And has it reached a stage of, I mean, let's be, I could imagine in the old days it might not have been the aesthetic or the real, how has it improved? Has it improved?
so
Is it very natural looking reconstructions that we get
the
nowadays?
tram flap,
Yeah.
which is transverse rectus
Yeah.
abdominis myocutaneous flap. That's a big long sentence, but it's also a big long operation, right?
Yeah.
So you know the six-pack that these
Yeah.
guys have?
Yeah.
Well, you and I, we have it, but we tend to hide it.
Yeah, well, saving it.
But the six-pack that the guys have, right? It's
Yeah.
a big muscle
Yeah.
that comes down here, right?
Yeah.
And it has very good blood supply, rich blood supply.
Right.
So for the tram flap, you take a paddle of tissue,
Yeah.
which is analogous to the amount of breast tissue you would have removed.
Right.
Right? So it's like a big flap of this.
We get you, yeah.
And then you bring it up with the muscle. You take
Yeah.
the muscle off the abdominal wall.
Yeah.
You bring it up, you implant it into the defect
Right.
there. Right?
Right.
And then you reconstruct the abdominal wall with mesh to
Right.
keep everything in.
Right.
So it's two big defects.
Yeah.
One you've filled
Yes.
aesthetically with a normal breast. It feels normal.
Right.
It acts normal.
Right.
The only thing is, you could do a nipple reconstruction, which is very involved.
Yeah.
Or a very good and viable option is just tattooing a nipple.
Right.
Onto the graft.
Okay.
And that looks very much like natural and normal tissue.
Good stuff. Josh, any other questions there? Is genetic testing / counseling for breast cancer available in Trinidad and Tobago? If not in public sector, where is it available in the private sector and the rough cost? Is genetic counseling or testing for breast cancer available? Can you discuss that topic there for the public there? What is genetic testing for breast cancer and
Right.
tell us?
So, as we had said way back in the beginning of the topic, it's an genetic abnormality of the cell that causes the cell to divide abnormally, right?
Yeah.
And you had asked a question about, what about the family history?
Yeah.
And we had gone on to say, well, sometimes it's a mutation in the DNA within that family that actually causes it. And this is what that question is alluding to.
Yeah, excellent question.
That, how can I know whether I am at this increased risk? So there's, BRCA1, BRCA2, P10, KRAS, these kinds of mutations, which are really, you don't really need to know the name, you just need to know the implication that it puts you at increased risk of breast cancer.
Right. So is it that the breast, who gets the genetic testing? Who would you recommend to get the genetic testing? Only those people that have family history, or any woman who could afford it, so to speak, financially?
Right. So if you
or is it that's somebody that's
so if you
who's the
have
patient?
an immediate relative, mother, daughter, sister
Yeah.
with breast cancer.
Yeah.
Generally, anybody under 50.
Yeah.
Or if you have multiple relatives on one side of the family,
You should get it tested.
you should get it tested done. And the other thing is breast cancer in the young.
Yeah.
Breast cancer in the young they should all get genetic testing.
Yeah. What do you mean by breast cancer in the young should get genetic testing? What do you mean by
breast cancer in
young relatives or young patients?
In young patients, their relatives should get.
Oh, the young, right.
Right.
Okay.
So if you have a 25-year-old, a 30-year-old, 35-year-old
with breast cancer, all their relatives should get tested.
Their relatives should get tested.
All right. We didn't answer the question fully. Is it available in the public sector?
It is not available in the public sector.
Yeah.
It's available in the private sector.
And let's give them a rough course, which nobody will hold you to, but if you could just have an idea.
It would have been, 10 years ago, it would have been several thousand US.
Okay. Prices probably came down.
Currently, it's actually the price is maybe 4,000 to 5,000 TT.
Right.
It's being done at several places.
Right, we wouldn't name it.
Yes.
Right.
I guess you could check on the internet and find it, but it's been done at several
Good
places.
question, viewer, and you got your answer there. That's a very insightful question. It's available in the private sector. There are different places that do it, and of course, roughly, do not hold us accountable to that. It's about 4,000 to 5,000 TT dollars. Josh, we have a few more. You could go ahead. Can men get breast cancer?
Yes, men can get breast cancer.
That was my next question. People don't realize that.
Yes. So
tell us about that.
So
how common is it?
It accounts for 1% of breast cancers. Men account for 1% of breast cancers. And it's important also for genetic testing. If you have a male relative with breast cancer, you should get genetic testing because it may mean that they have, or the family has a genetic mutation that predisposes you. So that's one of the main factors for men, the family history is genetic mutation. Yes, it's quite rare, but being just 1%, but yes.
Okay. All right, it's interesting. And they have to same self-examination.
Well, generally, a man's chest will be
you can
normal,
see any kind of
right?
visual.
So, and then
it's easier to see.
Yes, exactly. As soon as you find the lump,
yeah. Well, I think that viewer is really telling us that listen, men get it as well. He's telling us to tell the public that men get it as well.
They do.
Or she is telling us to tell the public, and that we need to be observant. If you see something on your chest, don't assume that it could never be cancer.
Yes.
Get it checked out.
Well,
even if you're a man.
Men should get it checked out if they find an abnormal lump.
Exactly. Josh, you could put up the next question, please. Will my breast cancer treatment affect my ability to have a baby? That's a difficult question for you, Doc.
So,
because you're not sure what the treatment is.
Right. So I'm assuming if you have breast cancer and you want to have a baby, you're still within that fertile age group.
Correct.
Right?
Let's assume that.
So one of the strategies that is used is either so you could have frozen embryos, right? You could freeze the eggs. You could do in vitro fertilization, freeze the embryos. You could do a part of an ovary, save it for ovarian oocyte retrieval or transplant, or you could save an entire ovary to be reimplanted after your surgery.
I mean, so straight up, does radiotherapy and chemotherapy affect your fertility?
Yes,
okay.
it does, but it doesn't. You can still get pregnant naturally, but most if it's available, you should do the fertility preservation strategies.
Right. But many people have come through breast cancer and still have babies and go into normal deliveries and everything.
Yes, you can have that.
Right.
But as I said, if you
increase your chances of
if you are very young, you probably should, because it will affect the egg quality and so on.
All right. Josh, we will push through. Do all breast cancer patients need chemotherapy, doctor?
Now, that is a difficult question. All right?
You sit in the hot seat,
Yes, that is a difficult question. There are some.
And I must say the public really is aware and have good questions for you.
Yes, they do actually. These are all excellent questions.
Yeah.
These are very involved questions.
Yeah.
So in the elderly patient, 70-year-old patient, they may just get away with, especially if they're hormone receptor positive tumors, they may just get away with hormonal therapy, something like tamoxifen or
Which is a tablet?
yes, or Arimidex and anastrozole, right? There are tumors, you know, the non-invasive ones, and tumors less than 0.5 centimeters, depending on the clinical characteristics of it. There are various subtypes when you go into the molecular analysis of it and the pathological analysis. There are some favorable subtypes, about 15% of them.
That might not need?
Right, that may not need, and based on the size. So once it's greater than 5 millimeters, you should get chemotherapy.
So there's specific types of cancers given specific characteristics in a specific individual patient that might not need chemotherapy, but so it's not the vast majority of them.
No.
It's a minority?
It's a minority.
Okay. That's
so by and large, the vast majority of patients will benefit from chemotherapy.
Will benefit from.
Yeah.
All right. So Josh, let's put up the last question there. What should I do if I find out I have breast cancer, but I am also currently nursing a newborn? Good question.
So
let's assume they're not on treatment. They could continue on breastfeeding. I mean, it's
no. If you have breast cancer, you need to address the breast cancer as soon as possible.
Right. But let's assume that they're addressing the breast cancer.
Yes. So it would mean once you're not on chemo, you can continue breastfeeding, but really and truly you would
but it would have an unaffected breast.
Yeah, but you would have systemic chemotherapy.
Right. No, I'm talking about, right. So if they're on chemotherapy, no.
Right. If they're on chemotherapy, no.
Yeah.
If they're not on chemotherapy, yeah, sure. You shouldn't have a contraindication, but you need to deal with the breast cancer.
Of course. Yeah,
right?
Of course.
You need to deal with the breast cancer, and they actually, it's a very specific situation, and it's even up to 1 year after delivery. You can. It can be defined as pregnancy-related cancer, breast cancer, right?
Right.
So they tend to be a little bit more aggressive, so you need to address that.
So you just put
really
out an issue there that might have breast cancer that might be related to pregnancy.
Yes.
Right.
Right, and because some of them are hormone-dependent tumors, and remember when you get pregnant, you have all this surge in all of the hormones that can actually drive that tumor to
aggression.
Yes, very severe levels of aggression.
And that's why you kept saying address the breast cancer.
Yes.
Address the breast cancer.
Yes, that is why.
All right.
Yeah.
Josh, have we left any question untouched? Here, good. Rashid, before we close off, right? Time ran away on us there. But I think it's very important too that if we take any patients all the way through, one of the big questions is when can a patient say that they have been cured from breast cancer?
So we spoke earlier about the 5-year survival rate, right?
Yeah.
So at 5 years, if you are cancer-free, you would have been considered to be cured of that specific cancer.
Yeah.
However, having had breast cancer before, you are at increased risk of having another cancer.
Yeah.
And therefore you need to undergo surveillance.
Right.
In a very rigorous fashion
to
make sure that you don't actually develop another breast cancer.
Another breast cancer.
Yes.
All right. So so the patient has gone through treatment.
Yeah.
It's gone into remission.
Yes.
But is there any time that the patient can say that they have been cured?
After 5 years?
After 5 years.
Yes.
And once, but you're maintaining vigilance and
Yes.
surveillance.
You must because you are at increased risk of developing another breast cancer.
All right, Rishi, we're totally out of time.
Yes.
The questions came flying in. I know you had loads of slides and pictures and images on your laptop. We didn't even get to any of them.
That's fine, no problem.
But two things. Thank you so much for coming in tonight.
My pleasure.
It's great to meet you. I mean, we met last week, and you have a wealth of information in there. Yeah. And I really appreciate the way you answered the questions. You really took your time, and you gave the right answer. And you made sure to give the right answer to the public. And thanks very much for coming out and putting out the information for the people.
Yeah, thanks for having me.
All right,
yeah.
You're very welcome. All right, guys, so, another interesting program. Again, thank you to Dr. Rishi Ramraj, consultant surgeon there at Point Fortin General Hospital, head of department, and he also has his offices in Gulfview Medical in Laramie. All right, guys, so thank you very much for tuning in tonight. I'd like to thank Josh for helping us out in the studio tonight and producing this program. All right, guys, so take care. God bless. We'll see you again next week. Take care, everyone. Have a pleasant evening now.